cardiac MRI role. Now we are going to discuss the role of cardiac MRI in the chronic chest pain, presented by Dr. Rana Tarek, lecturer of Radio Diagnosis, Ain Shams University.
Good afternoon, ladies and gentlemen. This is Rana Tarek, lecturer of Diagnostic and Interventional Radiology at Ain Shams University Hospitals. And I'll be talking about the chronic chest pain role of MRI. Actually, it's not only about the chest pain, it's about the chronic cardiac conditions. So the objectives and the outlines of my talk. My talk will cover the causes of cardiac chronic chest pain and heart failure, the role of MRI in heart failure assessment, role of MRI in chronic ischemic heart disease assessment, the role of MRI in dilated cardiomyopathy, and I will be reviewing some cardiac MRI techniques very briefly, and finally we will conclude. So regarding the heart failure, it can be acute or due to acute or chronic causes like ischemic cardiomyopathy, myocarditis, dilated cardiomyopathy, infiltrative disease, and many others. For the cardiac MRI in cases of heart failure, cardiac MRI plays an important complementary role to the echo. And according to the European CMR registry, the most common indications for CMR in heart failure include evaluating the underlying etiology or etiologies. It can be multifactorial of the suspected heart failure, risk stratification in cases of suspected ischemia, assessment of the viability, assessment of suspected underlying myocarditis and cardiomyopathy, particularly when the echo window is not adequate or the findings are inconclusive. So how can MRI help? Of course, the volumes and functions. Cardiac MRI is the gold standard for the assessment of LV volumes, ejection fraction, left atrial volumes, and right ventricle. And of course, the tissue characterization, and as Dr. Shayma has given some examples in the acute chest pain, the cardiac MRI helps in tissue characterization through several techniques, including the mapping techniques, and also for the thrombus imaging, we usually rely on the early gadolinium enhancement, and for the macroscopic fibrosis or the scar formation, the infarction, we use the late gadolinium enhancement, and for the diffuse fibrosis, we rely on the T1 mapping and the extracellular volume measurement, and usually we don't use the T2 mapping in the chronic conditions. And the European Association for the Cardiovascular Imaging recommended the use of the parametric mapping in patients with heart failure. So why is it important to assess fibrosis in cases of heart failure? That's because fibrosis is a common pathological manifestation in the heart failure, and the pattern of the fibrosis differs between different etiologies. And also, we should evaluate the presence and the extent of the LGE or the fibrosis. It can predict the prognosis in patients with heart failure, regardless the etiology. So starting with the chronic ischemic cardiomyopathy, brief introduction. Coronary artery disease is a common worldwide disease, and it can present with or without heart failure. The chronic ischemic cardiomyopathy is the most common etiology of heart failure, and it is a potentially treatable cause, and that's why it's important to discover it and diagnose it. For the role of cardiac MRI in ischemic heart disease, we need functional and volume assessment. We need the tissue characterization for the fibrosis and to exclude the presence of edema. And we can use also the myocardial perfusion and stress imaging. So I will not talk about the functional and volume assessment. As we've mentioned, it's already a gold standard technique, the cardiac MRI. I will focus in the next slides on the tissue characterization and the stress imaging. So for the fibrosis, in cases of ischemic heart disease, it can be a scar, an infarct, or diffuse interstitial fibrosis. The scar in the ischemic cardiomyopathy is usually subendocardial. I will show you the laser pointer. Okay, this is a subendocardial scar, which indicates the viability of the affected segment if it is not exceeding 50% of the transmural thickness. And this is a transmural scar, which indicates the non-viability of this segment, and it is territorial, as we can see. Cardiac MRI, of course, can affect the therapeutic decision. As I've mentioned, the presence of subendocardial or transmural can identify whether it is a reversible or irreversible myocardial injury before the revascularization. Also, cardiac MRI has shown to be superior to the SPECT with better sensitivity and specificity in the assessment of the myocardial scar, especially in the small scars. Coming for the mapping, the T1 mapping techniques, as I've mentioned, is used to characterize the diffuse myocardial disease. It can detect the focal, also if it is interstitial and not macroscopic. And the T2 mapping, we only or mainly use it to exclude the presence of edema or the presence of acute on top inflammatory or cardiac insult. And it's usually the edema is absent in the chronic ischemic heart diseases. And over the last years, the T1 and T2 mapping have emerged as promising myocardial characterization tools. T1 mapping can be acquired pre- and post-contrast with ECV quantification, and the native T1 mapping or the pre-contrast T1 mapping are elevated in cases of diffuse fibrosis. The ECV or the extracellular volume is calculated after giving the contrast, and it can also increase in cases of diffuse fibrosis or infiltrative disease. So it's very important to assess the T1 and the ECV values to confirm that this is just a chronic ischemia and we don't have an element of infiltrative heart diseases. Then coming to the myocardial perfusion and stress imaging, it has proven its reliability for the detection of stress-inducible ischemia in suspected ischemic heart disease, and it depends on the assessment of the myocardial perfusion using pharmacological stress testing. It's either using coronary vasodilators or using inotropic agent like the dobutamine. This is a perfusion study. We can see here during rest there is a uniform enhancement of the myocardium, but after applying or giving the patient a vasodilator, we can see here under stress there is a perfusion defect, indicating the presence of ischemia. And we can confirm that this is just an ischemia and not chronic infarct by correlating with the LGE images. If we can see a scar, then this is an established infarction. If there is no scar, then this is stress-inducible ischemia. And these are the indications for the stress cardiac MRI in 2021. It's already well established in the guidelines and recommended in several conditions in intermediate to high risk patients, whether they are known to have obstructive coronary artery disease or not yet known prior to the CABG, etc. For the perfusion, we use the vasodilator. The most common is the adenosine, where it increases the blood flow to the stenotic arteries and the non-stenotic arteries. But this is where occurs the coronary steal phenomena. The healthy arteries takes all the blood away from the stenotic ones, and that's where we can see or detect the ischemia or the perfusion defect. Like in this case, this is during stress after applying or giving the patient the vasodilatation. This is a stress perfusion defect. And it has shown to have better sensitivity and negative predictive value compared to the SPECT. Like here, this is the same case. I can detect here the perfusion defect in ischemia, but however here on the SPECT, I couldn't detect it. And also, as recently published, the stress perfusion has demonstrated its non-inferiority to predict the major cardiac events in comparison with the invasive fractional flow reserve. Other stress techniques, they are still under research. I will just mentioning it's named like stress T1 mapping without contrast and arterial spin labeling. So coming to the dobutamine stress MRI, here we use not a vasodilator, we use inotropics. Commonly the dobutamine, it increases myocardial oxygen demand compared to, which is comparable to physical exercising. It can be given at a low dose to recruit the contractile reserve of a hibernating myocardium. What's hibernating myocardium? It's a functionally impaired but viable myocardium. It's suffering from ischemia, and so to face this ischemia, it decreases its contractility. Or a high dose to induce myocardial ischemia in territories where significant coronary stenosis is there. High dose cardiac MRI is superior to the dobutamine stress echo in cases of its diagnostic accuracy. If you can see here, this is a stress dobutamine study during the baseline or during the rest. We can see every segment of the myocardial wall contracting well, but on reaching the peak stress using the dobutamine, we can see here that it is hypokinetic to akinetic, and denoting that there is here, this segment is suffering from ischemia. This is a quick review for the response to the dobutamine, which is having a good specificity and sensitivity. This is biphasic response, and this usually for the hibernating myocardium. At baseline it's good. At low dose it can increase in its contractility, but on reaching the peak stress it becomes hypokinetic, and on stress it comes back again on recovery to be normal. This is a biphasic response. And this is a viable myocardium that will benefit from revascularization. This is monophasic response. It increases with low dose and peak, and this is a non-phasic, indicating a scar where everywhere it is hypo to akinetic. We usually depend on the visual assessment. However, there are other semi-quantitative and quantitative methods for the perfusion imaging. And for the dobutamine stress studies, we can rely on the strain analysis for more quantitative method. This we can get in I will finish in 2 minutes. To obtain the quantifiable information about the wall motion, the concept of strain imaging has been established, and most common technique is the feature tracking. Like in this case, we acquire the CINI images, and on the regular CINI images, I can apply additional post-processing feature tracking strain analysis with no need for re-imaging the patient. And it depends on the longitudinal, radial strain, and circumferential strain. Definitely in the myocardial ischemic segments, the strain, the longitudinal strain will be affected. And recent publications have demonstrated the incremental prognostic value of the strain imaging in risk stratification. And of course, we shouldn't forget the AI, which can help us to use get automated volumes and functions, get automated detection and quantification of the scar, and quantification of the myocardial perfusion. Also with the strain, it can help a lot. For the dilated cardiomyopathy, it's common etiology and is characterized by ventricular dilatation. Of course, the late gadolinium enhancement is important, and in this case, unlike the ischemic, it's not subendocardial or transmural, and it's not territorial. It's usually mid-wall enhancement with increase in T1 mapping values, the native T1 values, and also the MRI can help in detection of the intracavitary thrombus formation. And definitely the strain analysis is well applied in these cases, and we can detect that there is an affection for the global longitudinal strain in cases of dilated cardiomyopathy, and this can detect the prognosis. And we shouldn't forget the heart failure with preserved ejection fraction. Not every heart failure means reduced ejection fraction. It can be with preserved ejection fraction, yet still have or has a diastolic dysfunction. other cardiomyopathies that can cause heart failure, like HCM, arrhythmogenic RV, and cardiac infiltrative disease will be discussed. Some of them will be discussed in the next talks. So to conclude, cardiac MRI has evolved into a major non-invasive imaging tool to guide the diagnosis, risk stratification, and management for patients with chronic chest pain. It can assess cardiac structure and function accurately and reproducibly, and its ability to characterize myocardial tissue can help determine the underlying etiology of the heart failure. And finally, the AI techniques are refining and the efficiency of the CMR analysis and reporting, especially in cases of the ischemic cardiomyopathy. Thank you.
Thank you, Dr. Rana, for this informative lecture.